Okay, in this session for pathological base of disease, I'm going to cover diseases of bone. And in this session, we're going to look at basic bone physiology. We're going to look at all of the cell types of bone, focusing on osteoblasts and osteoclasts. We're going to look at how these differentiate. So osteoblasts come from mesenchymal cells, osteoclasts from bone marrow, haematopoeitic cells. And we're going to look at the different differentiation pathways that these take, because we can potentially drug these pathways in bone disease. We'll then look at how altered bone turnover results in two main pathologies, that's Paget's disease and also osteoporosis, and we're going to cover pharmacological treatment of these diseases with some drugs that target the bone. And finally I'll show you some work that I'm involved in that looks at cancer-induced bone disease and how the pathways that we look at up here of the osteoblast and osteoclast differentiation can be used to study how cancers migrate to the bone marrow environment, and particularly cancers like breast cancer, prostate cancer can colonize the bone marrow cavity. So I'll give you a little bit of background onto that sort of work. So just to start off, bone is a dynamic tissue, so it's not just static mineralized tissue that many people think of. It's full of cells. There's constant replenishment of the bone, so bone's constantly being turned over, and this fact that 10% of your entire skeleton is replaced, and that is that the bone is eaten away by osteoclasts and replaced by osteoblasts every year. And a lot of the turnover is related to how much the bones flex under pressure. So being active and mobile results in more bone flexing, and therefore bones accommodate excessive stresses, so they no longer flex excessively and fracture. So getting around and doing more exercise will build bone mineral density and bone strength. Now if this bone turnover is uncoupled, that is, if degradation exceeds formation, you end up with disorders related to osteoporosis. Conversely, if the bone formation exceeds bone loss, you get net bone gain, and you end up with osteopetrosis. And these are two sort of opposing bone diseases. So this just shows the generalized structure of long bones and the key features that occur in it, particularly in the long bones, but this is common to lots of bones, is a bone marrow cavity. So femur, tibia, all the big bones have an extensive bone marrow cavity. However, so do most of your smaller bones as well. Even ribs and vertebrae and even fingers will have a bone marrow cavity within them. There's a growth plate here and here, particularly on the long bones at least. At the ends of bones you have this bone which is known as trabecular bone, sometimes called honeycomb bone, sometimes cancellous bone, and this is a very strong type of bone, very lightweight and strong. So all of these little this honeycomb structure gives the end, like here the end of the femur, incredible strength given its weight. The bone marrow cavity is where the majority of your haematopoeitic cells are made, and also a lot of those haematopoeitic cells will also be formed in these end regions here. The bone matrix has incredible strength, and that's because it is largely made up of collagen protein. So this is the generic structure of collagen. You should have covered it in biochemistry. It's a triple helical protein, and when it's laid down by the osteoblasts, which we're going to come on to fairly shortly, it will lay down collagen in long collagen fibers. These collagen fibers are laid down in layers in opposing directions. So one layer is running sort of that way, and then the next layer is running the opposite way, and that gives incredible strength for shear forces and stretching strength. And once that collagen is being laid down, which is obviously collagen is just a protein, then we get mineralization where calcium hydroxyapatite comes in and slots in between individual collagen fibers, and this is what we call the mineralization process, where the hydroxyapatite slots in between the individual proteins, and that creates the hard, white, mineral-like bone that we're all familiar with. Now this is just a cross section through a bit of trabecular bone. So the trabecular bone is that honeycomb-like bone, and it shows the major cell types of bone. So all of this pinky, purpley stuff here is bone matrix. So this is a section of bone that's been cut, and then a thin, maybe 10 micrometer section has been cut of that bone using a microtome. And all of the cells have been stained up with hematoxylin so you can see the nuclei. And the main cell types of bone are visible in here. Firstly, we've got the osteoclast, and this is this great big cell here. It looks like it's got multiple nuclei, and that's because it does. And there's another big fat osteoclast there. And these are formed from haematopoeitic cells which are fused together to create an osteoclast. And what the osteoclasts do is land on the bone surface and start eating away at it. And they secrete acids and acid-loving proteases to erode away at the bone. We've then got the osteoblasts, and these are the cells that synthesise new bone. They derive from your bone marrow stromal cells or mesenchymal stem cells, whereas your osteoclasts are from your haematopoeitic stem cells. So your osteoblasts, they line a bone surface that has recently been eroded away. So imagine this bit of bone used to go as a solid piece of bone here. An osteoclast would have landed on here, eaten away this, what we call a resorption pit, and then the osteoblasts sit on that surface and secrete new bone. And what we can see is the osteoblasts are these quite chunky, square-looking cells, and underneath them there's a layer of collagen that's been laid down that's not yet mineralized. So this is very recently produced collagen, whereas all of this stuff is old mineralized collagen. So the stain that's been used here identifies mineralized collagen. And there's another region down there where the osteoblasts are actively laying down new bone. So the other major type of cell in bone are the osteocytes, and these are encased within the collagen matrix. They derive from osteoblasts. So as these osteoblasts fill up a resorption pit, they occasionally leave one of their colleagues behind, and that cell turns into an osteocyte. And all of the osteocytes have little fibre-like networks, so this one will be connected to this one and connected to this one. And what they do is they sense bone stress. So if you get a fracture across here, all of these osteocytes will sense that fracture because the connection between this cell and this cell will be broken, and they will release factors to bring in an osteoclast to form a resorption pit or eat away at the damaged ends of the bone, and the whole bone remodeling cycle starts. So bone density is largely governed by microcracks that occur within bone. So a microcrack starts the process, let's say across here, and that can be in response to some sort of physical activity. Weightlifters in particular have very thick, heavy bones. It's not just that they've got a high genetic baseline for having big, thick, heavy bones. It's from constantly applying lots of pressure, causing lots of microcracks. If a microcrack occurs across here, the damaged ends of the bone will be eroded away by osteoclasts. Osteoblasts will fill in even more bone and make that stronger so that hopefully it doesn't fracture in future. And by repeatedly stressing bones, you can make bones incredibly strong as long as you don't stress them to the point of fracture. And this is how people who do martial arts and people who do parkour and people jumping off high buildings and hitting the floor, if they build up their bone strength steadily over time, they can, those who do parkour, they can jump off a garage roof, hit the ground and carry on running, whereas normal people firstly wouldn't do it, and secondly would hit the ground and break their ankle. So they can only do that because they have repeatedly conditioned their bones. And the same is true with people who do martial arts, and they will condition their bones by punching things. When you get really advanced in martial arts, you would go out and punch a tree trunk, and normal people would just break their wrist, whereas people who've conditioned their bones have created increased bone mass, and that allows them to do these crazy things. Conversely, anyone who's experienced a long period of inactivity will have lost bone mass, so people who are horizontally in a hospital bed for 6 months at a time will lose a significant amount of their bones, because the osteoclast will still go around nibbling away at bone, but the osteoblast will not really fill in that bone, and you end up just losing bone mass. And it's a real problem with astronauts, and that's why astronauts on the International Space Station have treadmills and they're strapped down with rubber bungees to try to create some bone stress to prevent them from getting bone loss and osteoporosis, which we're going to come on to in a moment. So firstly, we're going to look at how the osteoclasts form. And osteoclasts, they resemble macrophages to some extent. They derive from haematopoeitic cells, derive from monocytic cells, and they differentiate to a fully fledged osteoclast with that multinucleate formation that we saw earlier via RANK and RANK ligand interaction. RANK is just a receptor activator of NF-kappa B. RANK ligand is the ligand for receptor activator of NF-kappa B. And RANK ligand is on your osteoblasts and your stromal cells. RANK is on the osteoclasts. So if this pathway is defective, you can get a disease called osteopetrosis. It's an inherited disorder where either the RANK ligand or the RANK can be defective. The net result of this is you get normal bone formation, so the osteoblasts still function, but you then don't get the osteoclast forming, and you end up with just a build-up of bone. And in this situation, osteopetrosis, the bones are much thick. The cortical bone is much thicker than normal. The bone marrow cavity is very narrow, and you get to the point where, in advanced stages, the bone marrow cavity is effectively lost due to the thickness of the cortical bone. Now, in these hereditary types, there are two different types, and there's a lab at the Sheffield Children's Hospital that researches this, because one of the treatments for osteopetrosis is a bone marrow transplant of the haematopoeitic cells. So it's really important to know whether osteopetrosis is caused by a defect on RANK on the osteoclasts or RANK ligand on the osteoblasts. If RANK on the osteoclasts is defective, then a bone marrow transplant, which will replace the patient's entire haematopoeitic system, would be a treatment for this particular disease. However, if the defect is on RANK ligand, this would not work, because the osteoblasts are not replaced in a bone marrow transplant, so you would be replacing the patient's haematopoeic cells, normal haematopoeic cells, with more normal haematopoeic cells. You've still got defective osteoblasts, and therefore the transplant would be a waste of time. So it's really important to study these patients and find out the exact cause of their osteopetrosis prior to doing this. So this slide shows the RANK ligand system in osteoclast activation, and there's also OPG, which is another component of this. So RANK ligand is on the osteoblasts and bone marrow stromal cells, and this activates a pre-osteoclast via RANK ligand interaction. So here's our bone marrow stromal cells. Bone marrow stromal cells give rise to osteoblasts. Bone marrow stromal cells have got RANK ligand. Your pre-osteoclasts, which are monocytic-like cells, express RANK. You get this interaction. You get these activated cells fusing together to create a large multinucleate osteoclast. That osteoclast can bind to the bone surface and erode it away. And this pathway has got a natural negative regulator, and that negative regulator is osteoprotegerin, and that's derived from osteoblasts and bone marrow stromal cells, and its job is to negatively regulate this process. So once osteoclasts are being activated, you then want to be able to negatively regulate this process to switch it off so you don't get excessive bone resorption, and then the OPG can bind to RANK ligand and block RANK ligand from binding to RANK. If OPG binds to RANK ligand, you don't get your osteoclast formation and you don't get bone resorption. So anything that can block RANK ligand could potentially be something that could prevent bone resorption, and we'll come on to that later. Okay, so the second major pathway that controls bone is the Wnt pathway, which controls osteoblast formation. So osteoblasts are derived from bone marrow stromal cells, which themselves are derived from mesenchymal stem cells. And the Wnt signalling pathway will drive osteoblast differentiation. So Wnts are growth factors. They're secreted, short-acting in terms of distance, and they will bind to the receptors on the recipient cells that are called frizzled and abbreviated FZD, but whenever you see this, it's frizzled, which is the name of the Wnt receptors. There are loads of different Wnts, and there are loads of different Wnt receptors, and this is one of the many stem cell signaling pathways that control cellular differentiation. So without Wnt signaling, the bone marrow stromal cells go down the adipocyte lineage, which is the fat type cells, and you see this in old patients, so their bone marrows are what we say they've got fatty marrow, whereas younger patients tend to have got very little adipocyte formation. So any defect in the Wnt signaling pathway can cause either bone loss or bone gain, depending if that defect is an activating or an inactivating mutation. So this Wnt pathway controls osteoblast activation. So Wnts are secreted in the bone microenvironment. They will bind to frizzled, which is the Wnt receptors, and they also bind with the LRP5 or LRP6, which is a co-receptor. LRP5 is the low density lipoprotein receptor related protein 5 and 6, if you were interested. So this frizzled and LRP5 complex signals to the bone marrow stromal cells that they need to turn into osteoblasts. So they will be activated after the osteoclasts have eaten away a bone resorption pit shown here. They will differentiate into osteoblasts, they will land on the bone surface, they'll secrete collagen, and they will result in new bone formation. This pathway also has a negative regulator pathway, and this is the DKK1 and Frisbee pathway. DKK1 is Dickoff1, and Frisbee is frizzle related protein B, I think, but both of these are negative regulators of Wnt signaling. So to prevent constant osteoblast formation, and what happens is once osteoblasts have been formed, you then want to prevent more of them from being formed because we only need a certain number at any particular time. So DKK1 and Frisbee can bind to the frizzled LRP5, LRP6 receptor complex and prevent new osteoblast formation. And if you have excessive amounts of DKK1 or Frisbee, you can completely prevent osteoblasts from creating new bone. Right at the end of this lecture, I'll show you some x-rays of cancer-induced bone disease, which is my particular interest. And one of the things that I've been working on in the past is looking at how tumour cells overexpress Wnts, and prostate cancers overexpress Wnts, and they drive excessive bone formation. So this pathway, that makes sense given this pathway. And then other cancers such as breast cancers and multiple myeloma overexpress DKK1, and what they produce are tumours in bone that are what we call osteolytic. So you've got great big holes in the bone because they're expressing vast amounts of DKK1. There are no bone marrow stromal cells around the tumours, and you end up with lytic bone disease. So have a look at the x-rays right at the end of this lecture, and hopefully this would then make sense. Okay, so we move on to osteoporosis now. So osteoporosis is this imbalance of osteoclast and osteoblast activity, usually in the favour of osteoclast activity. That is, your osteoclasts are working faster than your osteoblasts. And if you look at these two sections of bone, this is normal trabecular bone and this is osteoporotic trabecular bone. And if you were to take a line across here, you would see that to fracture this bone, you would have to break the bone at lots of different places. There's much more bone density here, whereas here you've got great big holes, and this trabecular bone is therefore weakened. So if you drew a line across here, you've only got 1, 2, 3, 4, 5 little bits of bone. So this could easily fracture along this axis, whereas this one would not. And this is a problem with osteoporosis. You lose bone mass, and therefore the trabecular bone is often very much weakened, and that makes patients very susceptible to fractures when they fall. So in different patients you may see different patterns of activity. You may see both osteoblast and osteoclast activity increasing, but with osteoclast activity increasing more than osteoblast activity, resulting in a net bone loss. So the key point here is the bone formation and bone loss is uncoupled, and that is, in osteoporosis, bone loss is occurring faster than bone formation. Even though you could have both osteoblasts and osteoclasts working faster than in a normal person, if one works faster than the other, the whole process is uncoupled. So osteoporosis, we get decreased bone density, and we find patients with very easily fractured bone. Predominantly affects many more women than men, and this is because after 30 years of age, bone mass peaks, and then bone resorption rate exceeds bone formation, particularly in the menopause. And this is because the osteoblasts themselves require estrogens for survival, and as estrogen levels fall, osteoblasts tend to hang around for less amount of time, so the population might start filling in a resorption pit. In low levels of estrogen, they would then de-differentiate or just die, and that leaves those resorption pits unfilled. So initially we'd say that the patients are osteopenic, which is a lower than normal bone marrow density, and then when bone marrow density gets to a certain threshold, we say that the patient is osteoporotic. And we lose the bone mass mostly initially in the trabecular bone, and remember, trabecular bones at the end of the femur, at the end of the long bones, within the vertebrae themselves. And you can also get these things called osteoporotic vertebral compression fractures, where you've got multiple fractures over time that result in this wedge-shaped vertebra, and that's why you get that classic osteoporotic stoop in many old ladies, where their vertebrae have become wedge-shaped, and that gives a certain curvature to the spine. And this is all down to loss of bone mineral density within those vertebrae. Now, osteoporosis can be diagnosed by X-ray, and we use a dual X-ray absorptimetry test, and this involves taking X-rays from various different angles, particularly looking at the head of the femur, and then we're looking, I wouldn't worry too much about all of these little triangles that are drawn, but there's a particular region that we take for looking at the bone mineral density. And what we do is we plot the bone mineral density against age, and so here you can see as patients age, bone mineral density normally will decrease, and using these sorts of plots based on somebody's age, we can say whether they are more than one standard deviation below the mean for their age group, and if they're less than what, if they're in, so this is a normal distribution of bone mineral density for a set age group, and if a person has got this bone mineral density, they're bang on average. Osteopetrosis will be way up here. If they are one standard deviation below the mean, they are osteopenia. If they are 2.5 standard deviations below the mean, by definition they are osteoporotic. So the DEXA scans are used to identify patients who are at increased risk of developing osteoporosis. So it's nice to catch patients who are in the osteopenic range, where we can actually increase the bone mineral density before they then start having fractures. And then if we can identify the osteoporotic patients, we can give drugs that will prevent further bone loss. So this slide sort of reiterates what I said about the menopause and why women particularly develop osteoporosis, as we can see bone mass reaching a peak at around the age of 30, and then plateaus and then rapidly drops off in menopausal women, and then continues to decline in postmenopausal women. So this is why this condition predominantly, not exclusively, but predominantly affects females, whereas males, testosterone levels drive osteoblast survival, so they are to some extent protected from that. So men don't get away with it. Older men, if they suffer from any bone disease, it could well be Paget's disease of bone. So this is associated with a localized overproduction of bone. Now, this particular population are often asymptomatic or mildly symptomatic, but a lot of them are found incidentally by having bone scans. So if a patient's having a bone scan for prostate cancer, I mentioned earlier that prostate cancer often metastasizes to the bone. What we do for these patients is inject them with a radiotracer of technetium-99. That intercalates in with new bone that is being laid down, and then we can do a bone scan to see where new bone formation is occurring. In prostate cancer, you get focal points of new bone formation. In Paget's disease, you get entire regions of long bones, here the pelvis, here the tibia, that are affected. You often also get an asymmetrical presentation of this disease. So this disease is caused by osteoblasts. Often we think that the osteoblasts have become transformed, not transformed enough to become cancerous, but overgrowing, and they're basically refusing to die when they're supposed to die. And we know this because of Paget's disease patients, if they live for each decade of life there's a few percent of those patients who will develop primary osteosarcoma from an existing Paget's disease lesion, which suggests that these lesions may represent a pre-malignant stage of osteosarcoma, and if this patient lived long enough, they may well develop osteosarcoma from one of these lesions. But we say it's idiopathic. There's no known cause other than presumably random DNA mutations in osteoblasts. So the problem with Paget's disease, and this is a different case, and you can see a very the skull affected here. The problem with it is you get excessive bone formation, and that excessive bone formation is what we call pagetoid bone or osteoid. And osteoid is unmineralized bone. So what's happening in Paget's disease, you've got excessive bone formation that is unmineralized, and that easily fractures. And so what happens, you have cycles of producing vast amounts of new collagen which is not yet mineralized, then it fractures, and that induces more osteoclasts to go in, repair the damage, and more osteoblasts to go in, and it's sort of self-perpetuating loop of new bone formation and repair, but the new bone never really mineralizes properly, it never becomes particularly strong, and therefore it fractures really easily. Now if we want to study what's going on within the bone, yes, we can do x-rays and we can do technetium-99 bone scans, but we can do far less invasive or complicated tests. We can do simple blood tests to find out what's going on within the bone. And I'll just remind you of the structure of collagen here. Here's a collagen triple helix, and when collagen is laid down, it is laid down as a pro-peptide. A newly synthesized collagen has the what we call the P1MP, which is the pro-collagen type 1 N-terminal pro-peptides. So that's this bit. So this bit is cleaved off when the collagen is laid down, and then this is the mature collagen that is actually laid down. Then you've got the telopeptide here, a telopeptide here. There's also a C-terminal pro-peptide, but the P1MP, the N-terminal pro-peptide, is the main one that we can look for in blood. So if you've got high levels of P1MP in blood, that suggests there's lots of bone formation occurring at that given time. And another confirmation of this is alkaline phosphatase. So osteoblasts secrete alkaline phosphatase, and if there's high levels of alkaline phosphatase, that suggests that there's high levels of bone formation going on. There are other alkaline phosphatases, and liver alkaline phosphatase can sometimes interfere with this test. But that's two key markers of bone formation that can be tested for in blood. So in a Paget's disease patient, you would expect these levels to be high. If a patient's got prostate cancer metastasized to the bone, you would expect these two markers to be high. And in the lab in my old lab where we used to work, we used to screen patients who were thought to be having prostate cancer metastasis. They were high risk, and we'd actually use ALK-Phos and P1NP to predict who would develop a metastasis in the future. At the same time, we'd also pick up lots of patients with Paget's disease, because if we had increased ALK-Phos and P1NP in the blood, those patients would be sent off for a bone scan to see the extent of the prostate cancer metastasis. And in about half the cases, we'd find that the patients had got raised P1NP and ALK-Phos because they actually got Paget's disease, not metastatic prostate cancer. So that's how those two diseases are often talked about at the same time, because we often find Paget's disease on the basis of raised bone markers because we're suspecting they might have got prostate cancer metastasis. Some of the other bone markers that we can look for include CTX and NTX. So CTX is the collagen C-telopeptide that contains a cross-linking site. So here's a triple helix. This triple helix of collagen is cross-linked from one strand to another, and at the telopeptide, basically the end bit that is laid down here and here, these bits are part of the mature collagen. So if you ever see telopeptides that have been cleaved and chopped up enzymatically floating around in blood, that must mean that bone is being actively resorbed. So we use CTX and NTX as an indicator of increased bone resorption. Because if you think the only way that you can get this telopeptide out of collagen is if an osteoclast has secreted acid-loving enzymes that have degraded, removed the calcium hydroxyapatite and then proteolytically cleaved the collagen. So the pro-peptide predicts bone formation, the telopeptide predicts active bone resorption, and that is a marker of osteoclast activation. Now there's one other enzyme that's not on this slide, but it might be relevant in a moment or two, which is an enzyme called TRAP5AC, and this is tartrate-resistant acid phosphatase, and that is an enzyme secreted by osteoclasts. So you can look for TRAP5 levels within blood, and that would suggest that there's osteoclast activity going on. So we can affect bone loss by using this class of drugs called bisphosphonates, and anybody who works in the medical school in Sheffield would, let's say if you're going out there on placement, you'll come across bisphosphonates endlessly. There's a big bone research group, the Mellon-B Bone Research Group up there. Western Park Cancer Hospital is always doing clinical trials on bisphosphonates. And the reason why is because the whole idea of these bisphosphonates was developed partly in the University of Sheffield's medical school, and this was one of those odd conversations between somebody who was looking into water softeners and someone who was a bone biologist. And the person who was looking into developing washing machine softeners like Calgon and that sort of thing were interested in this class of chemicals that they found that could bind and chelate calcium. And the bone biologist had heard this idea and thought, well, maybe we could use that as a drug and modify the structure of the bisphosphonates that were being used as water softeners and get them to stick to the bone surface. If you can get them to stick to the bone surface, you could potentially poison osteoclasts and prevent bone resorption. So a lot of that early work was done up at the med school at Sheffield in the what is now the Mellon-B Bone Research Centre. And this is the class of drugs that were initially developed, and they resemble pyrophosphate, and pyrophosphate is part of one of the minerals which binds to the bone surface to mineralize the bone. So we're creating a drug that closely mimics pyrophosphate. Instead of having an oxygen here, we've got a carbon here, and that allows us to put two R groups, and those two R groups can carry some sort of toxic payload that will only be encountered by an osteoclast eating that bone. And this is just summarised here. Don't worry about the top half of this pathway. It's just that the nitrogen containing bisphosphonates, which are the most active ones, block this well-known pathway which particularly affects osteoclasts. It will affect all cells, but only the osteoclast will have their mevalonic acid pathway disrupted because they're the only ones that are going to actually consume the drug. So there's the bone, there's a bisphosphonate lining the surface of the bone, the osteoclast comes along, tapes up the bisphosphonate, and the osteoclast dies. So it's a really clever way of drugging a particular cell type. So we can use bisphosphonates to successfully treat bone disease, and this is showing osteoporosis over a period of 4 years at the spine and at the hip, and this axis is change in bone mineral density. And what we can see is here's the placebo group and here's the alendronate, which is bisphosphonate, and we can see when we give the bisphosphonate you get an increase of bone mineral density over 4 years, whereas in the placebo you get a decrease. At the spine you get a much more impressive increase. Now what's interesting there is you do get an increase with the placebo. Now this is normally because patients diagnosed with osteoporosis are given either, in a clinical trial they will be given either current best practice, which is exercise, improved diet, vitamin D, calcium supplements, physio, that type of thing. So by doing that alone, by doing more exercise, they may well mitigate some of the osteoporotic changes. So the key point here is there's a huge difference between the alendronate treated and the placebo at both locations, but the fact that the current best practice after diagnosis may be preventing bone mineral density loss. Now, bisphosphonates can also be used to treat Paget's disease. Now, even though Paget's disease is the treatment of an overgrowth of osteoblasts, the whole cycle of Pagetoid bone being produced is reliant upon osteoclasts acting as well. So by this particular study was looking at placebo, which is there over time of 0 to 6 months, and this is serum alkaline phosphatase change from baseline. So I mentioned earlier ALK-phos is an enzyme that is secreted by osteoblasts, and any changes in that relate to what's going on in the bones. So we can see that the placebo is either flatlined or gone up a little bit, whereas treatment with etidronate or Fosmax, which is a formulation of a different bisphosphonate, all show really significant decreases in alkaline phosphatase, showing that by targeting the osteoclasts you are closing down this vicious cycle of Pagetoid bone fracturing, osteoclasts trying to repair the damage, producing more osteoblast activity, and by preventing that cycle, that self-perpetuating loop, you have now managed to alleviate some of the bone formation going on in Paget's disease. Importantly, this data confirms that there's an underlying osteolytic component to Paget's disease that is helping to drive what we call the osteosclerotic or bone formation part of the disease. And osteolytic and osteosclerotic will come up later when I talk about cancer-induced bone disease as well. Now, the bisphosphonates are very good drugs for treating bone diseases, and they're long-acting, so one dose of zeledronate maybe lasts on the bones for 6 months or so, so that's a very good drug in that respect. There are a few problems with it. There's some side effects, particularly you get osteonecrosis, particularly in the jaw, lower mandible area. So there are some concerns with this. It's not a perfect drug. There are now some biopharmaceuticals which do work on the same pathway, and one that you'll be particularly interested in is denosumab. So this is a RANK ligand blocking monoclonal antibody. So here's our stromal cells, here's our RANK ligand. We know that RANK ligand binds to RANK on the surface of preosteoclasts. That drives osteolysis. What we can do is give denosumab as a monoclonal antibody. It's anti-RANK ligand, it blocks RANK ligand, it prevents RANK interaction, and therefore prevents osteoclast formation. So the RANK ligand is doing a very, very similar job to what osteoprotegerin did on a very similar looking slide earlier on. And this denosumab is very much of an alternative drug to give in replacement to bisphosphonates. So just like before, in comes the denosumab, that will inhibit osteoclast formation, and we'll get no bone resorption going on in that situation. So I'm now going to move on to metastatic bone disease. So this is where cancers from one particular site migrate to the bone marrow cavity and form a metastatic lesion there, and when they do that they form very characteristic lesions within bone. And the three major types you should be aware of are multiple myeloma. This is a plasma cell, antibody secreting cell that has become malignant, and they form osteolytic lesions. Breast cancers, when they go to the bone marrow cavity, also form osteolytic lesions, and prostate cancers form osteosclerotic lesions with an underlying bit of osteolysis. So these are all three different cancers, providing, resulting in slightly, different bone morphologies, and we know why they do this, because they alter the pathways that we've just been studying. So here's a TC99 pyrophosphate bone scan. So we inject in this radio tracer, and that goes to any region of bone where there's active bone formation going on. This is a case of prostate cancer that's metastasized to the bones, primarily the ribs, the vertebra, bits in the end of the bones here. So all of these little black dots, with the exception of the bladder, because that's just where the radio tracer was accumulated, all of the others are individual prostate cancer metastases in the bone causing new bone formation. Whereas on your Paget's disease you can see these long lesions. So this is how we can tell the difference between an old patient at risk of prostate cancer metastasis having metastasis versus having a very similar set of symptoms of bone pain and pelvic pain, but that could be due to Paget's disease. So a bone scan tells the difference between those two. And the reason that you get this type of thing, this type of lesion, is because the prostate cancer cells themselves overexpress the Wnt. So the Wnt are sort of being secreted by the prostate cancer cells, driving their own growth, and in doing so they're also driving the osteoblasts to overgrow to some extent, and you get osteosclerotic bone lesions, which are often quite lumpy. When you take an x-ray of them, the bone surface is often what we call craggy and lumpy. In complete contrast to that, this is a patient with multiple myeloma, and this is something that's known in the trade as the pepper pot skull, where the skull contains lots of holes, and these holes are induced by the cancer cells sitting on the bone surface. And in this case, the cancer cells, what we found when we started looking at these cells, is they express lots of DKK1. Now DKK1 is a Wnt antagonist. So DKK1 is secreted by the myeloma cells. That prevents the formation of new osteoblasts. The osteoclasts can still do the function, and therefore you end up with lytic lesions around where a deposit of multiple myeloma cells have found themselves. There is an idea that the multiple myeloma cells can also express RANK ligand as well to drive this osteolytic activity. However, that evidence is now becoming seen as less reliable, and certainly the DKK1 is the much more reliable marker of osteolysis in multiple myeloma. Similarly, breast cancer, metastasis to the bone marrow, you get an osteolytic lesion. So here's a tumour where it looks like this entire bone, which is a fibula, I think, has almost completely eroded away because the cancer's grown within the bone marrow cavity. We've got near complete bone loss. That bone's compromised and will fracture. And again, we've found that lots of breast cancers overexpress DKK1. So one of the main cell lines I work on is MDA231, which is a breast cancer cell line, and that secretes vast amounts of DKK1. If you do experiments to DKK1 where you knock out the DKK1, put those cells into an experimental model, such as in mice, they, instead of forming osteolytic lesions, they will form osteosclerotic lesions, proving that DKK1 is the key mediator of osteolysis. There's another cell line that I work on called PC3. That's a prostate cancer cell line. Now this is unusual because that also forms osteolytic lesions, but that also expresses vast amounts of DKK1. And what we found is when we neutralise DKK1 in that cell line it went from having osteolytic lesions into osteosclerotic lesions, again further proving that the expression of DKK1 was absolutely fundamental to the formation of the type of lesions. Now we don't entirely know why this occurs, but there is a hypothesis that DKK1 enhances stem cell characteristics, and those two cell lines, MDA231 and PC3, have very good sort of stem cell characteristics. They have really good self-renewal abilities, and we think that the overexpression of DKK1 might be related to their ability to proliferate long term, but that's all ongoing research. And this is sort of summarised here. I mentioned earlier about prostate cancer going to the bones, and this is a prostate cancer metastasis, and you can see that the bone surface looks craggy, there's excessive bone formation, whereas on the previous slide it's the same bone but you've got this great big hole in the bone there. So the reason why they are so different is all down to the breast and myelomas that secrete Wnt antagonists, particularly DKK1 but possibly FRISB to some extent, whereas most prostate cancers tend to express high levels of the Wnt's, therefore driving the opposite of osteolysis, which is osteosclerosis. Okay, here's a summary slide of many of the key points that are important that I've covered in here. Also, being that this video is uploaded to YouTube, have a look at the other videos on the channel. There will be loads of videos on there which will be really useful for your final year. So if you're doing cell pathology and infection, there's loads of cancer biology lectures on there. But just have a peruse around the channel and see if there's any interesting lectures that you're interested in, and give it a like if you like it. Thank you.